Hi friends, welcome back. Today we can see another type of superficial infection, that is dermatophytosis. Dermatophytosis is a most common type of superficial infection caused by fungus seen in man and animals. It is mainly affecting three sides: skin, hair and nails. The prevalence of dermatophytosis, it is mainly governed by environmental factors, personal hygiene and individual's susceptibility. Transmission, it is occurring mainly through fomites. Fomites are inanimate objects which can transmit infection. The main categories of dermatophytes are based on the ecological characteristics. Dermatophytes are traditionally divided into three categories. They are anthropophilic, zoophilic and geophilic. Anthropophilic, they are exclusively affecting human beings. Zoophilic, they inhabit domestic wild animals and birds. Geophilic, frequently seen or isolated from soil. Personal habits, living conditions, warm moist climate, minor skin trauma or injury are contributing factors in facilitating the infection. Certain cultural and traditional practices are also related or correlated with the greater occurrence. For example, wearing tight dress, walking barefoot, sharing of shaving instruments, etc. Certain occupations like farmers, athletes, wrestlers are also at high risk. Transmission, it is mainly through fomites. Some are endemic. Most common etiological agents are Trichophyton rubrum and Microsporum canis. Coming to the pathogenesis, the dermatophytes, they mainly grow only in dead keratinized tissues. Fungal cells produce keratinolytic proteases enzyme and this provides the entry into living cells. Erythema, vesicle formation, pustule formation along with pruritus are the main symptoms. Variation in clinical presentations can be seen depending on the species involved, strains of fungus involved, size of inoculum, involved sites and immune status of the host. We can see variation in clinical presentation. The clinical features. Clinical manifestations are also called tinea or ringworm. The following clinical conditions can be seen or can be produced by dermatophytes: tinea capitis, tinea corporis, tinea imbricata, tinea gladiatorum, tinea incognito, tinea facie, tinea barbae, tinea cruris, tinea manum, tinea pedis, tinea unguum, onychomycosis, deep dermatophytosis, ID reaction and non-dermatophytic dermatomycosis. First we can see tinea capitis. Infection of hair shaft of the scalp. Two types can be seen, inflammatory type and non-inflammatory type. Infected hairs, they are appearing dull and grey in color. Base of hair shaft and its follicles are involved. Breakage of hair at the follicular orifice creates black dots of broken hair. Predominant causative agent is Trichophyton genus. Various clinical types of tinea capitis are reported. First one is carrion, painful inflammatory type and severe form with deep separative lesions at multiple points on scalp. Pus will be discharging from the follicles. Thick crusting will be formed. The thick crusting, it is associated with matting of adjacent hair. Scarring and permanent alopecia is the result, that is permanent hair loss. Causative agent is Trichophyton varicosum and Trichophyton mentagrophytes. Carrion cell C is a clinical form seen in children. Second one is favus or tinea favosa. It is produced by Trichophyton violaceum and Microsporum gypsum. Form cup-like crust around the hair follicles. Intense fungal growth seen in and around the hair follicles. Produce a waxy honeycomb-like crust in the scalp. Here also we can see hair loss and scarring. Black dot, usually caused by Trichophyton tonsurans and violaceum. Attack the hair shaft with abundant invasion and sporulation inside the hair. Breakage of hair near the surface of scalp resulting in a black dot appearance. Fourth one is ectothrix infection. Here we can see arthrospores as a mosaic sheath around the hair or as stain on the surface of hair shaft. Cuticle remain intact. Arthrospores may be small or large. Then causative agents are Trichophyton mentagrophytes, Microsporum canis and Microsporum varicosum. Endothrix infection. Hyphae form arthrospores within the hair shaft. Hair shaft is weakened severely and the cuticle is destroyed completely. Arthrospores, they may be 3 to 4 micrometers in diameter. Causative agents are trichophyton species, that is tonsurans and violacea. That's all about TINEA capitis. Second one is TINEA corporis, also called TINEA glabrosa or TINEA glabrata. It is causing infection in non-hairy parts of the body. Many may result from extension of the infection from scalp, groin and beard, characterized by erythematous scaly lesions. It's most commonly seen in India, or the most common type in India, mainly caused by Trichophyton rubrum. Infection of hair follicles leads to elevated crested granulomatous lesions called Majoc's granuloma. Majoc's granuloma, here localized cutaneous dermatophyte infection of dermal and subcutaneous tissues, also called TINEA profunda. Two types of clinical manifestations can be seen: perifollicular papules and nodules in healthy persons with chronic dermatophytosis. Second one is deep nodular abscesses in immunocompromised, mainly AIDS patients, organ recipients, etc. Most common causative agent of Majoc's granuloma is Trichophyton rubrum. It is affecting scalp, face, forearms, hand or legs. Third clinical manifestation is TINEA imbricata. Then unusual form of TINEA corporis. Only causative agent is Trichophyton concentricum, found in China, India, Polynesian islands, etc. Characterized by concentric rings of scales which spread out peripherally over many years. Cover almost all hairless skin. Intense pruritus can be seen. The predisposing conditions are humidity, inheritance and immunological factors. Chronic and highly relapsing disease. Oral griseofulvin, terbinafine, Whitefields ointment, etc. are effective. Pseudo-imbricata can be seen, which is caused by dermatophytes other than Trichophyton concentricum. It gives rings within ring or double-edged tinea appearance. Next one is TINEA gladiatorum. Emerging infection in wrestlers. It affects their ability to compete. It is also found in athletes as a result of direct skin-to-skin contact in wrestlers. Mostly lesions appear on arms, trunk, head and neck. Commonest isolate is Trichophyton tonsurans. Outbreaks have been reported. Fluconazole, it is effective and is safe for treatment. Next is TINEA incognito steroid modified tinea, that is as a result of misuse of corticosteroids in combination with topical antimycotic drugs for treatment of dermatophytosis. Disturbance in classical clinical pattern of particular tinea leading to delay of diagnosis, hence it is also called tinea atypical. It may resemble dermatitis, psoriasis, etc. TINEA fasciae, it is the infection of non-bearded region of face similar to TINEA corporis, form erythematous annular plaques with central clearing. Next is TINEA barbae, ringworm infection of beard and mustache area of the face, also called tinea psychosis or barber's itch, caused by sharing of cutting scissors and shaving blades. Erythematous patches on face show scaling, fragile hair and a tendency to develop folliculitis. Two clinical types can be seen: deep nodular type caused by Trichophyton verrucosum and mendagrophytes, superficial crusted type caused by Trichophyton violaceum and Trichophyton rubrum. Next is TINEA cruris, occurs worldwide, more common in tropical regions. Infection of groin, mostly seen in men due to long-term use of tight-fitting garments. Involves perineum, scrotum, perineal area, buttocks and occasionally to thighs. Spread can be seen. Scaling is variable, also called Jock Itch because itching is the predominant symptom. Trichophyton rubrum and Dermatophyton floccosum are the main causative agents. TINEA MANUUM, infection of palmar aspects of hands. Most common clinical manifestation is diffuse hyperkeratosis of palms and fingers. Infection is caused by Trichophyton rubrum, Trichophyton mendagrophytes and Dermatophyton floccosum. TINEA pedis, it's an infection of plantar aspects of foot, toes and interdigitating web spaces. Warmth and moisture produced by shoes is the key factor for infection seen in people who are wearing shoes for a long time, popularly seen in athletes, so it is called athlete's foot. In the toe webs, scaling, fissuring, maceration and erythema may be associated. with an itching and burning sensation. Small vesicles ruptures and discharge thin fluid. Due to cracks, there is a chance of secondary bacterial infections also. The infection of the sole extends to the side of the foot and also known as moccasin or sandal ringworm, also called one hand, 2 feet syndrome. In chronic cases, sole is covered with fine scales and the causative agents are trichophyton species and epidermophyton. On the basis of clinical presentation, TINEA pedis can be of 4 types: interdigitalis, hyperkeratotic, ulcerative and vesicular. Interdigitalis, here we can see fissuring, erythema, scaling in the toe webs between 4th and 5th toes. Simplex and complex types can be seen. Then hyperkeratotic means scaling and hyperkeratosis can be seen. Ulcerative means ulcerative affecting soles with oozing. Vesicular consists of vesicles and blisters. TINEA INCOGNITO dermatophyte, infection of nail plates, disease of adults caused by trichophyton and epidermophyton, can affect entire nail plate and nail bed. Poor peripheral circulation is frequently implicated for resistance to treatment. Onychomycosis is a general term to denote all fungal infections of nails. Causative agents are again dermatophytes, toe nails more affected, common infection in adults. KOH preparation can be used for confirming the clinical diagnosis. 3 groups of fungi are associated with onychomycosis: dermatophytes, non-dermatophytic molds, yeast, particularly Candida albicans. Classification of onychomycosis. On the basis of types of lesions, onychomycosis are classified into 4 types: distal and lateral subungual onychomycosis, that is DLSO, most common; nail bed and underside of the nail plate affected. Common species is Trichophyton rubrum. Then ideal site for specimen collection is nail bed. Proximal type, that is affects fingernails primarily due to Candida, inflammation, pruritus, purulent discharge. Specimen taken from nail plate can be used for diagnosis. White superficial onychomycosis, surface infection of nail. Causative agent is mentagrophytes, found in AIDS patients. Then scrapings can be used for diagnosis. Then total dystrophic onychomycosis, it is the total destruction of nail plate and infection caused by dermatophytes. Deep dermatophytosis is another type, that is deeper infection like abscess formation can be seen, caused by trichophyton, mainly affecting the outermost layers of the skin. Sometimes deeper invasion seen in immunocompromised patients. Fungi enter the bloodstream and disseminate to major internal organs, resulting in fatal systemic infections. ID reaction or dermatophytid reaction, it's a secondary eruption seen in sensitized TINEA patients due to circulation of allergic products, frequently found in patients with absence of delayed reactions to trichophyton antigen, also developed following the commencement of oral fungal therapy. 2 main types can be seen: lichen scrofulosaurum like, that is seen associated with TINEA capitis in children, and follicular lesions can be seen. Horny spines can be observed in the top of the follicles, and then second one is pombolix like, that is the lesions seen in fingers and palms in TINEA pedis. Here we can see papillar, vesicular or sometimes pustular, appear on sides of finger, wrist and all over the body. Non-dermatophytic dermatomycosis, here the infection of the skin, nails, and is caused by fungus other than dermatophytes. Some examples are Candida and Fusarium. That's all about the clinical manifestations of dermatophytosis. Hope you all understand the session. Thank you. Have a nice day.